Awesome. Well, thank you so much for joining us. And to those who've been with us for the earlier part of the series, welcome back. We're excited to kind of be going into the fifth session with one more to come on December 11th. The topic of this week is Justice on the Front Lines, Case Studies in Community Healthcare, and the potential for Medicaid 1115 policy to serve as a practice-changing tool. Very excited to introduce you to our speakers and kind of get started in conversation. Before we begin, just a huge thank you again to Sandra Susan Smith, Katie Naples-Mitchell, and Brian Welch, without whom this could not be possible, and are all wonderful members of the Harvard Kennedy School Malcolm Weiner Center for Social Policy. So thank you to everyone. I'll be your moderator. This is my email address. Please feel free to reach out at any point with questions, concerns, or ideas that you'd like us to bring up or share in our last sessions of the series, and anything you'd like to see kind of moving forward. So I just want to introduce those of you who haven't actually joined us previously, to kind of what the inspiration for this series came from. And it was a convening at the Harvard Radcliffe Institute earlier this year, where we brought together experts from across the country in the field of justice health and kind of asked, what are the 5 biggest problems that we need to solve to address inequity in healthcare provided to justice-involved patients? We had some wonderful outcomes from those conversations and came up with kind of 5 principles. The first one was the idea of, there being a attention that we needed to draw towards narrative and issue framing. Secondly, defining what standards of care look like in the justice health space. Thirdly, privatization and financing, and how that poses a huge barrier and cause for consideration in this space. Oversight, accountability, and transparency, inclusive of quality data metrics, which we've explored quite a bit through the series. And then challenges to, and the notion of alternatives to incarceration. And today we're going to have the opportunity really to kind of dive a little bit into the idea of challenges to and alternatives to incarceration. Today, not as much about incarceration alternatives itself, but alternatives to how we work with the current carceral system, particularly related to healthcare, and opportunities to kind of redesign the system, particularly related to things like reentry and community programming. We'll also kind of take a look at narrative and issue framing, and how the patient perspective and the perspective of physicians in the field of social justice and social emergency medicine, for example, kind of play into this space. So I want to get started by introducing our incredible guests, Mary Bassett, John Card, Margaret Hayden, and Sanjay Kishore. We're so lucky to have you all. Thank you for being here. Dr. Mary Bassett is the director of FXB Center for Health and Human Rights at Harvard University, as well as the FXB Professor of the Practice of Health and Human Rights at the Harvard School of Public Health. With more than 30 years of experience in public health, Dr. Bassett has dedicated her career to advancing health equity. Prior to serving as the director of the FXB Center, Dr. Bassett served for 4 years as Commissioner of Health for New York City. As commissioner, she worked to ensure that every New York City neighborhood supported the health of its residents, with the goal of closing gaps in population health across the city. Originally from New York City, Dr. Bassett also lived in Zimbabwe for nearly 20 years. Previously, she was the program director for the African Health Initiative and the Child Wellbeing Program at the Doris Duke Charitable Foundation. She received her Bachelor of Arts in History and Science from Harvard University and her medical degree from Columbia University's College of Physicians and Surgeons. She completed her medical residency at Harlem Hospital Center and holds a master's degree in public health from the University of Washington, where she was a Robert Wood Johnson Clinical Scholar. Welcome, Dr. Bassett.
Thank you very much.
Of course. Next, we have John Card, who joined the Center for Health Law and Policy Innovation of Harvard Law School in 2002 as a staff attorney in the Health Law and Policy Clinic. Prior to joining the center, John was a staff attorney at the Health Law Institute in Jamaica Plain, where he provided free legal services to people living with or at high risk of HIV. His prior work focused on a variety of areas, including tenant rights, public benefit appeals, and criminal record sealing. John also has expertise in LGBTQ+ organizing, harm reduction, and substance use disorder, as well as policing and public health. John graduated from Northeastern University School of Law in May 2019 and is a licensed member of the Massachusetts Bar. Welcome, John. Next, we have Dr. Margaret Hayden. Dr. Hayden is an assistant professor of medicine and the associate director of health humanities at the Center for Health Humanities and Ethics at the University of Virginia. Previously, she was an assistant professor of medicine at the University of Alabama, Birmingham, and worked as a physician at the Equal Justice Initiative, EJI, where she helped to establish a clinic that provided free transitional primary health care to people leaving jails and prisons across Alabama. In that work, she focused on the development of an innovative hepatitis C treatment program. She received her Bachelor of Arts in Human Biology at Stanford and completed an honors program in ethics. She has a Master of Philosophy degree in medical anthropology from the University of Oxford, where she was also a Rhodes Scholar. She earned a medical degree from Harvard Medical School and completed her primary care internal medicine residency at the Brigham and Women's Hospital and worked as a primary care provider at Uppins Corner Health Center, a federally qualified health clinic in Dorchester, Massachusetts. She is a certified HIV specialist from the American Academy of HIV Medicine. And last but not least, after these illustrious colleagues, we have Dr. Sanjay Kishore. Dr. Kishore is an assistant professor of medicine at the University of Virginia. He too was previously an assistant professor of medicine at the University of Alabama, Birmingham, and worked at the Equal Justice Initiative, or EJI, to provide transitional primary care to individuals recently released from prison and jail with a focus on hepatitis C evaluation and treatment. He received his Bachelor of Arts in Social Determinants of Health at Duke University and earned his medical degree from Harvard Medical School. He too completed internal medicine residency at the Brigham and Women's Hospital, where he also served at the Uppins Corner Health Clinic. Welcome to our panelists. Thank you so much. So let's go ahead and get kind of deep dive into these two issues, which we're kind of going to help merge together throughout the course of our conversation, thinking about narrative and issue framing, as well as this idea of what we can do to sort of alter the system that we are working with and think about alternatives to the current system of incarceration. I want to get started by thinking about, frontline work and the future of policy. Since our last series, we had the election, and I know that the next 4 years have brought on a lot of discussion and ideas that we can brainstorm together about what the future of policy might look like for all the folks on this call that are kind of involved in frontline work, whether that is, related to our professional circumstances or being friends and family members of folks who are involved in the criminal legal system. Of note, we have the opportunity to speak with a few physicians today and lawyers to kind of talk a little bit about what the perspective also of doctors in social justice could look like. I think we've kind of touched on this theme a little bit throughout the series, but I wanted to draw our attention to two kind of ways of framing the role of physicians in social justice and kind of the healthcare space that complicate and I hope become something that we can kind of talk about and problem solve together as we think about how we're organizing and approaching the next 4 years. This article, It's Like Heaven Over There, Medicine as Discipline and the Production of the Carceral Body, was an article that really touched upon what medical trainees from a very young kind of part of medical training are exposed to and how medical students really start thinking about working with the justice-involved patient population. I thought this quote was really interesting, and I'll go ahead and read it. Medical trainees grapple with being beneficiaries of a state and institutional power structure that exploits the neglected health of incarcerated patients for the benefit of medical education and research. The benefits include the training opportunities afforded by the advanced pathologies suffered by persons who are incarcerated, and as we'll speak about today, including hepatitis C, an institutional culture that generally allowed students more freedom to practice their skills on incarcerated patients as compared to free world patients, and an easy compliance of incarcerated patients likely conditioned by their subject. It is a complicated space that we're going to be talking about and a complicated space for our frontline health providers to be working. I don't know if Josiah Rich is on the call, but Dr. Rich and his colleagues wrote this article, which also kind of provided a little bit of a lens for perspective called Physicians in U.S. Prisons in the Era of Mass Incarceration. And this was back in 2010 and still holds very true today. I'll read a small excerpt. Physicians, including 3 of the authors of this paper, with the best of intentions, inadvertently have lent their support and reputations to the program of mass incarceration simply by working for and with the institutions. Without their profession's involvement, mass incarceration would not be legal, as prisons in the United States must provide adequate medical care to pass constitutional muster, and physicians are required to provide that care. So as we think about kind of approaching this space, physicians and frontline workers as kind of both a necessary component and an agent or tool at times, it's I'm really looking forward to kind of sharing some perspectives about how we approach this very delicate and complex matter. Dr. Bassett, of course, can start us off by sharing her perspective with many years of work in this field, and a quote that has always stuck with me, where she said, "Our role as health professionals is not just to treat our patients, but to sound the alarm and advocate for change. Rightfully or not, our societal position gives our voices great credibility, and we shouldn't waste that." So, Dr. Bassett, I'm teeing you up to introduce us a little bit to your incredible work in this space, really starting with kind of the idea that you've written so much about how racism leads to disparate health outcomes. And of course, your work in the Black Panthers Roxbury Clinic as our first case study to kind of take a little bit of a look at how you were able to marry the idea of, serving as a physician in the community and kind of marrying that with the racism and institutional and structural violence that you've spoken about that kind of frames that. For those who don't know much about it, Dr. Bassett will share us a little bit, but Time also did a very interesting video about the history you didn't learn about the Black Panthers and their role in the clinics. And if you'd like to read a little more about this, of course, Dr. Bassett was in Politico, kind of talking about her work in the Black Panthers Clinic in Roxbury when she was a Radcliffe College student, as partaking in part of the sickle cell screening program, and really noted that these clinics were a form of restorative care and an organizing tool. So Dr. Bassett, I will turn it over to you to just share a little bit of your perspective on, what this model really proved and what has stuck with you over the years.
Well, thanks very much for that introduction, Kara. I should first point out, as we are asked to do now, that I'm speaking in my personal capacity as a member of the Harvard faculty and under the institutional voice principles not as the center director. So fortunately, a lot of what you're interested in talking with me about today refers to work that I did long before I even considered that I would be on the faculty at the Harvard Chan School of Public Health. I was an undergraduate when I worked at the Black Panther Party's Free Health Clinic. I think in the end, they ended up having about 13 of these around the country. And they put health into the 10-point platform, which was, in retrospective, a really democratic, if radical, platform that spoke to the idea that people have rights that are fully in accordance with the Universal Declaration of Human Rights. I was really proud to be the Thursday clinic person. I got Harvard professors to come work there, and I didn't even know who they were. Many of them were rather prominent, it turned out, and they worked and took supplies from Harvard and outfitted this clinic. It was a different time that faculty members, would have. It's hard to imagine now, actually. So the idea here was that the pursuit of health was was a political project. It wasn't simply about delivering health care, but supporting communities and advocating for their needs. So by going door to door, talking with people about screening for sickle cell anemia, the party members who did that were alerting members of the community to their interest in this. The public image of the Black Panther Party, probably to this day, was of, the people walking in formation with guns and black berets and looking really gorgeous, actually. But people, I think, often were unaware of the social activities that the Black Panther Party considered that were fully within what they saw as their mandate. And they did things like organized for travel to incarcerated individuals. They, had many services, not just the clinic, free breakfast programs. It was really an example of filling in an absent service that people should have been able to receive from their governments. And in that regard, it really was showing what an organized collective response can mean. Um, so I'll stop there. I'm not quite sure that whether or not that was what you were thinking about. Um, but it was, it was an important experience for me, obviously, and I took the opportunity to elevate it when I was the New York City Health Commissioner.
Absolutely. Yes. Thank you. That's a perfect kind of context for us to kind of look at where your work really took off from there. So, using this as kind of,
Mm,
early exposure to one case of community healthcare, you went on to, and, of course, this, during COVID-19, community healthcare became a very important model for us to think about. And this legacy really helped kind of shape some of the local interventions, and another time kind of piece that had highlighted how that continued to serve as a really important model of what we can really kind of go on. But
absolutely.
you went on after your early undergraduate days at
Mm,
Radcliffe to really write in the most prominent, arguably journal that we have in medicine about the challenge of racism in public health communities. And this article came out in 2015, and 5 years later, kind of writing still about, potential of reparations as a public health priority, a strategy for ending Black-white health disparities, and also about how structural racism works and policies as a root cause of racial health inequities. I think this work, very much kind of pushes us in the justice health field, who, of course,
mm,
as we've spoken about throughout the course of this series, um, you know, face incredible racial disparities in who and why and how persons of color end up in carceral settings.
right.
And I just wanted to kind of take a minute to think about when you talk about why your doctor should care about social justice. And we in this group think about, doctors certainly, because I do think, as you shared, that there's an incredible amount of privilege afforded to the voice that we can give. But more
Mm.
broadly, like, how does your work kind of potentially lay the groundwork for, the idea of where we go from here? And I know you've spoken and said, I did everything I could, but I knew that epidemics emerge along the fissures of our society, reflecting not only biology, but more importantly, patterns of marginalization, exclusion, discrimination related to race, gender, sexuality, class, and more. And that certainly carries into jails and prisons.
Yeah.
So, in your perspective, kind of reflecting on this, what might sounding the alarm look like for physicians or other healthcare providers who bear witness to the invisible epidemics that are happening behind jail, prison, and detention center walls?
I'm not actively working in this space now, but as the New York City Health Commissioner, the health department had oversight of medical services within the jails, which is unusual. Many places, those are under the authority of the the correctional people, and not under the separate authority of, in our case, the health department. But I'm assuming that you all have been over some of these numbers. First, the astounding differential risk of encountering the criminal legal system, particularly for African Americans as compared to other groups, and ending up incarcerated. And the massive size of the carceral system, in terms of who's held within it, who works in it, and its importance in our economy. So I assume that all of this you all know. And this occurs in the setting of massive inequities in health. The likelihood of dying prematurely remains vastly higher, at least twofold higher for people of color than it is for people of African descent, actually, than it is for other groups. And this many people view as the most important indicator of structural racism. Premature death, death before the age of 65, is the most important measure that we have in terms of the health impact of structural racism. So one thing that we can do is to work on showing how this works. And that's what some of the articles that we wrote, um, you know, was an attempt to do, and I'm really delighted that you found so many of them and I guess read them. Um, the other is to use our standing to say that this does not reflect some kind of inherent biological or cultural disposition of the people who have ended up in behind bars. This reflects inequities in our society. Uh, all the likelihood of encountering a police officer, surviving that encounter, ending up arrested, ending up incarcerated, the bail system, the the legal system, the likelihood that you will uh, be be found guilty, the duration of your sentence, all of these are filtered through white supremacy. And, the health impacts occur both to the individuals who end up in this system and to the communities that they leave behind. And, I don't know what else to say about this system other than it should get smaller. The first step should always be that we have to talk about what's going on, that we have 2 million people incarcerated in this country. 20% of the world's population of incarcerated individuals, 4% of the world's population. So the first step always has to be speaking about decarceration. And during COVID, I actually did do something as a faculty member. I circulated a petition among the in the health area, calling for the release of individuals from the Massachusetts prison system who had been convicted of nonviolent crimes, uh, with the argument that COVID should made being incarcerated a potential death sentence, and that people who had been, convicted of nonviolent crimes shouldn't be sentenced to the risk of death. Interestingly, we got many more signatures from the medical faculty than the public health faculty.
Mm.
Uh,
Yeah, it's really interesting.
so, I don't know. I mean, I think that raising our voices, talking about the importance of shrinking this system, of coming up with alternatives to cash bail, which at least 30% of people can't afford to pay, talking about the risks of harm simply through incarceration and the harms that happen to people who are left behind, who face loss of income, loss of housing, and many mental health effects of having loved ones behind bars.
Absolutely. Thank you so much, Dr. Bassett. And we'll continue to kind of hear from your perspective as we move through our cases to kind of reflect on a couple different examples of where we might take our, experiences in the next couple of years. So I know you guys know that you're coming next. Dr. Kishore and Dr. Hayden are going to kind of give us a little bit of a perspective into a state of Alabama that is, certainly a unique place where a lot of these challenges play out. And I'm very eager to learn from kind of some of their experiences and perspectives, as I think it's often hard to connect across the country to a lot of places where our justice involved patients are being seen in clinics more rurally and not as in like big urban centers. So case 2 brings us to Montgomery, Alabama, where the Equal Justice Initiative has really helped shed some light on the health impacts. For example, here, denying hepatitis C cure to incarcerated people and the risk to public health. And they really, with EJI's massive kind of established media and ability to kind of reach into other spaces, this is the mission of EJI that they've kind of used to approach this health topic. EJI is committed to ending mass incarceration and excessive punishment in the United States, to challenging racial and economic injustice, and to protecting basic human rights for the most vulnerable people in American society. For those of us in the space, this is a big voice and a big organization that we kind of look to. And I was really pleased to see in the last couple of years this push to really incorporate health as part of the approach to this mission. Dr. Kishore and Dr. Hayden served in Montgomery in one of the EJI's first health clinics, and receiving some recognition across the country as well. National Viral Hepatitis Roundtable to address HCV among the recently incarcerated in Alabama, and really helping to like raise and sound the alarm in their own way. This is the example of one of the mobile vans that I'll let them speak a little bit about, that they were able to kind of roll out in Montgomery to reach patients. And I wanted to hand it over to the two of them to just learn a little bit about their expertise in this kind of different case study and different context, and some perspectives from Alabama.
Yeah. Thanks so much, Kara, and really an honor to be part of this conversation, to follow Dr. Bassett and to hear about your leadership in these matters over the many years, all the way dating back to you being an undergraduate. So thanks for having us here. Happy to share really briefly about our work in Alabama and share a case study, and then definitely want to leave lots of time for questions and conversation. As Kara was saying, EJI has done work in this space for decades, direct legal representation of people on death row, people and representing people in class action suits about prison conditions in Alabama, and had done sort of reentry work as part of that, but had never been able to, had seen the need for healthcare and never really had the opportunity to work in that space. That changed about 2 years ago, 2.5 years ago. Sanjay and I, we are married, so that's partly why our stories sound so similar. We came down to Montgomery 2.5, almost 3 years ago, with a small team, with the goal of creating some direct healthcare services. And we really did it outside of the traditional healthcare system. In part, that's because Alabama is a really tough place to be in. Not only does it have incredibly high rates of incarceration, incredibly dismal prison conditions, the Department of Justice has been actively suing the state of Alabama Department of Corrections. It also does not have Medicaid expansion. The only way you get Medicaid in Alabama is if you have a dependent child and you make less than 18% of the federal poverty line, which is like less than $5,000 a year for a family of 3. So there's very few routes for a non-disabled adult to get onto Medicaid in Alabama. So EJI had seen this giant vacuum. They had seen clients getting out of prison and just had incredibly poor access to. So we did our best to sort of think about models to fill that. We developed a free clinic that had both a physical location in Montgomery and this mobile van that we drove to parole centers across the state. And we offered basic primary care. Being outside the traditional healthcare system has a lot of opportunities, but also challenges too. We were able to do basic screenings and sort of point of care lab equipment. We could do blood work and check for kidney disease and diabetes, HIV and hepatitis C, and do basic medications. We zeroed in on hepatitis C as a particular focus because there's a huge need. This is like a deadly bloodborne virus. Rates are incredibly high in prisons across the country. In Alabama, it's estimated about a third of people have active hepatitis C, and treatment rates are like less than 5%. And the sort of miracle of hepatitis C is it's actually easily curable with 2 to 3 months with pills. It does not require injections. It doesn't require hospitalization. The pills work 95% of the time. It's like one of the most powerful interventions I can give as a doctor. So we figured out how to do that from this van and from our clinic. We got diagnosed people and got them the meds, relying on some funding from EJI and philanthropy, and then donations from the drug companies. And then in addition to that, we did basic primary care, blood pressure, diabetes, so basic mental health services. But again, without the full spectrum healthcare that we would all aspire to, that everyone has a human right to. I can share a very brief case, sort of representative of some of the patients we saw, and Sanjay can share some reflections, and then we can leave it open for more conversation. But as one example, we saw a gentleman, Mr. M, who had served, he was 59 years old when we met him. He had served 39 years of a 40-year sentence and had been released with supervision to serve the last like 10 months. And so he was part of a parole program, which had an ankle monitor. He had required to attend classes, could not get a job as part of the sort of strict rules of his parole release. When we saw him, he actually didn't identify medical problems. He was focused on arguably more of the essentials, figuring out a place to live, figuring out how to pay for food and those sorts of things. he had actually a bit of a complicated medical history. He had a gallbladder surgery while incarcerated. It had a complication. It required a more extensive abdominal surgery and transfer to a larger hospital, and sort of a version of a gastric bypass surgery. So he's at risk for a lot of nutritional deficiencies, but hadn't been followed up on. He said he hadn't seen a doctor in years, was not on any medications, had a bit of like an itchy, scaly rash that he was like, this is bothering me somewhat, but as someone who just not really had any healthcare experience apart from this complicated abdominal surgery that he had acutely managed while incarcerated. And so we did our basic workup. We talked to him for a long time. He was very interested in blood work. We did the tests that we could do, and we found a few things. One, he had very high blood pressure that was untreated. Two, he did have hepatitis C. He had never been told about it. It was unclear if he had been screened in his almost 40 years in Alabama prisons. And then he had several nutritional deficiencies, like things that we had not, like scurvy, for example. He had things that we just don't see that often outside of these sort of extreme conditions. And so we did our best to help him with these. We were able to get him on basic blood pressure medications. We were able to treat his hepatitis C. We just got the lab work back a few months ago that he's officially cured. So that is sort of a real something we can hang our hat on. We helped him get supplements for his nutritional deficiencies, and EJI social work and legal side was also providing support around housing. He's in many ways done very well. He's still struggling. He's someone who's really would like to get a job, and as we've discussed in this series, it's very difficult. He has got denied at Walmart because of his record, and so is continuing to struggle to sort of figure out the basics of how to provide for himself in a way that he really hopes he could be able to. A challenge for someone who spent his literally entire life in Alabama prisons. But I think his case is representative of both the promise and the challenges of these sorts of interventions and trying to do healthcare outside of the traditional system.
Yeah, I think just a couple of reflections for journeys like Mr. Adams and some of the other patients we had a chance to meet. As we think about how to improve health in this post-incarceration period, first barrier number one is quality of care actually inside prisons. We could debate whether physicians should be justifying our presence in these institutions, but people are suffering and the quality of care is variable. Hep C is just one example of something that's being sat on, leading to morbidity and mortality. Even if once you leave, though, for a gentleman like him, the access piece, multiple barriers, top of mind for us was the lack of insurance. We talk about healthcare as a human right. It's not. It's just fundamentally not there. Folks struggling to make it, even if they wanted to go to a community health center, $30 copays to see a doctor, $200 Quest diagnostic bills to get basic lab work, paying for x-rays out of pocket. How are you going to get a colonoscopy, a mammogram, cancer screening? Like, there's no answers here, right? So the access piece for coverage. Even if you had some kind of coverage, though, across the whole state of Alabama, massive primary care shortages. Just the actual direct provider piece is a challenge of itself. And then finally, the reality is there's stigma. A lot of doctors are doing their best in a place like the Deep South, but there's some that harbor views that these folks did something that, why should they be ones prioritized for treatment when there's so many others that could have been? Didn't they deserve, the fate that befell them? That's a reality, particularly for folks that have struggled with substance use disorder. So challenges on multiple fronts. I think we felt in some small way EJI was able to help Mr. N, but I think one reflection that was really powerful for us, one of the mantras from the lawyers and the folks at the Equal Justice Initiative is, each of us is more than the worst thing we've ever done. That's something that's in the water, and it's something that, we've tried to learn from and imbibe to our core. When we were able to get this gentleman a course of antivirals for hepatitis C, the way he processed that, it was almost like a moment of grace. It was for him, he realized this wasn't solving all his problems in life, but it was, I know this organization cares about me. I know somebody cares about me. It's an affirmation of my worth, my dignity, my intrinsic human dignity. I don't know. I think, we stand on the shoulders of giants as medical students. I remember sitting in Dr. Bassett's classroom as a medical student, like learning from heroes and heroines. For those of us that are medical professionals and aspiring medical professionals, like that's why we do this. And so I hope that in kind of the conversations that we can have, be thinking about how do we create the structures where we can have moments like this, where we can just be a part of that journey.
Yeah, I think the tension and parts of interventions like the one we had in Alabama and perhaps the Black Panthers clinic too, is that I think being outside of traditional healthcare gives you a different footing with which to make connections and build trust with people who have been so disturbed by traditional services. And so in some ways it opens doors. I think it gives spaces to create moments where things like dignity and grace and redemption, like you can feel that flavor in the air in a way that's very hard in a traditional healthcare setting. The challenges, and something we were aware of as physicians who were trained in Boston and sort of had a sense of what the standard of care was, is that we knew for Mr. M, we did great things for him. We got him his cure of hepatitis C, but could we get him the standard of care that we believe he needs? No, like that, it was hard even with a nonprofit that had a lot of funding, a dedicated team, in the absence of a pathway towards coverage and a connection to the broader healthcare system, it was still hard to reach that standard of care that we knew he believed. And so that was a tension that we were constantly living in during this work.
Yeah, we're curious how John can help us solve these problems.
You guys are doing the work for me for segues now. I think it's incredibly powerful to think about, just human dignity at the core of this. And I started the series with those two kind of papers because I think they provide a moment to pause and like kind of weigh this scale that we're constantly weighing of, as medical students and residents and attendings now, just kind of weighing what it feels like and what the system has created, that you feel like you're, in some way can't get away from feeling like you're endorsing by serving as a clinician in that system, but inevitably, like believing so deeply that human dignity is deserving in all spaces of society, and being willing to kind of take on those layers of complexity, constantly doing this work of like, I'm not endorsing the system, but everybody suffering in this system and in this like sort of carceral space of confinement deserves the best quality of care. And if I can help provide, high quality, standard evidence-based care and model that, for not only what other patients deserve, but other providers in that space that could benefit from the value that we see in serving in that space, it's that, kind of you're holding everything at once. And I think that, Dr. Rich and his colleagues in the other article kind of, I think it's important to voice that that's what's happening and that's why this feels so difficult and challenging. But that at the end of the day, in patient-centered care and knowing that the families, as Dr. Bassett was saying, the ripple effects, carry into those communities, like doing everything we can to just hold all of that together, honor all of those tensions, and still kind of wake up every day and seek to serve in whatever capacity we can. And I think, it was very, very, insightful to kind of learn from, especially the Alabama example, where we don't get to have that perspective kind of as much. And, Dr. Kishore and Dr. Hayden mentioned John's work. And I think that John's work really kind of leads us into thinking about, not only holding all of these perspectives, but also hopefully holding the perspectives of, mapping new ways to think about this space. So I'd love to transition kind of to hope, maybe courtesy of Medicaid, and from John Card's perspective of kind of how this future of 1115 waivers might allow us to kind of move the mark a small bit on allowing this tension to really be actualized and realized into programmatic means. So John has done so much work. He's, housed kind of home base is the Center for Health Law and Policy Innovation at Harvard Law School. But really working with kind of the Centers for Medicare and Medicaid Services about what the, ways to navigate this space might be. And I'd love to just highlight this incredible article that John and Elizabeth Kaplan just released to Health Affairs about using Medicaid 1115 reentry waivers to improve the health of people leaving incarceration, highlighting a couple things that I'll just lay the groundwork for John's expertise to take from here. But that the Medicaid statute has generally prohibited the use of Medicaid funds to pay for the healthcare of a person in a carceral facility. That's been a major limitation over time. But there's emerging guidance around the idea of improving the care transition for people leaving incarceration and potentially piloting a provision of services for a limited period of time just prior to release to help smooth that pathway. In January of 2023 in California, they became the first 1115 waiver state to provide pre-release Medicaid coverage for people exiting state carceral facilities. And since that time, pretty incredibly, in August of 2024, John and his team were noting that 25 plus states and growing have sought approval for pre-release programs in Medicaid coverage. Now, I want to highlight what Sanjay and Margaret mentioned, which is this applies only to states that have undergone Medicaid expansion decisions. And so this Kaiser Family Foundation infographic kind of reminds us that as of February 2024, 40 states and DC have expanded Medicaid. We can kind of highlight where our friends at EJI were here in Alabama, knowing that this kind of gives us hope and a moment of pause that this is not going to be equally applicable in all places. And I'm sure as many of us are wondering, the next 4 years holds a lot of uncertainty related to Medicaid and the state of expansion decisions. So John, I know that's a lot to discuss, but I wanted to highlight where you guys can start to maybe click on this QR code or use your phone to activate the QR code here and take a look at the work that John and his team have been doing to really start tracking this uptake in Medicaid 1115 reentry with a very comprehensive spreadsheet of kind of the different states, the different eligibilities, the type of plans. It's a wealth of information and really, really exciting to kind of think creatively about where we could go from here. So we'll put the tracker up again if anyone would like to see this QR code, but I'm going to hand it over to John to talk a little bit about their, the work at the center, because one thing, kind of echoing what the other two case studies have brought into the lens is that a really inclusive and collaborative approach to program design of these 1115 waiver programs that prioritizes participation from formerly incarcerated voices and experiences has been a huge priority for John and his team. So John, go ahead and take us into your mind of promise and perils related to 1115 and where we might go from here.
Sure. Thanks, Kara. So first, thank you to our audience for joining us today. And again, thank you, Kara, and everybody on your team for such a wonderful series. I feel really privileged and lucky to be in this space with so many health and justice-oriented folks, especially on Trans Day of Remembrance. And specifically, I'm really excited to have a captive audience interested in hearing about 1115 waivers. They're, not the sexiest topic in the world at the outset, but hopefully by the end of here, you'll see all of the vision and promise that Chilpy is excited about. Chilpy is the acronym for the organization that I work for. I think it would be helpful for us to zoom out a little bit and maybe talk about what 1115 waivers are, and then I can dive into the specifics of reentry waivers and then talk about some of the promise and opportunity that we see becoming available through these programs. So I know Kara briefly touched on this, but 1115 waivers refer to a section of the Social Security Act that allows states to request a waiver of certain Medicaid requirements. So I want you to think of eligibility requirements or changes to the scope of allowable services. So they're much more expansive than just the reentry component that we're going to be talking about. When we talk about 1115 reentry waivers for short, we are referencing a type of 1115 waiver, which allows states to partially remove that federal ban that Kara mentioned. It's unfortunately deemed the Medicaid inmate exclusion policy. That is not my language. That is the formal term for this policy. And I think maybe the outdated language reflects some of the outdated thinking behind that policy. And hopefully we'll see some of that go away in the coming years. So in effect, these waivers allow states to provide limited health insurance coverage in the time leading up to someone's release from incarceration and back into the community. As Kara mentioned, we have the first waiver approved in January 2023. Some guidance came out from the Centers for Medicare and Medicaid Services shortly after. And in the interim period, we've seen 10 more approvals, and I think around 30 states have shown some level of interest in 1115 waivers, whether that's a legislative proposal or actually applying for one through the Centers for Medicare and Medicaid Services. So we have a pretty significant opportunity here. We have a lot of attention on providing services in the pre-release period, but it's proving to be fairly complicated. So let me dig into what exactly these waivers do. So as I mentioned earlier, reentry waivers do not fully remove the Medicaid inmate exclusion policy. Instead, they dictate mandatory and discretionary components for states seeking to pilot these programs. So waivers must include 3 services in order to, pass go. So first, that is case management for post-release planning and connection to health-related social needs like housing, employment, or transportation. Number 2, they have to provide medications for addiction treatment and behavioral health supports. And then 3, they have to provide medication in hand upon release from the facility for 30 days. States may request additional services, and I certainly hope that they do. We have some thoughts around what additional services might be most helpful. Namely, I would like to connect back to Sanjay and Margaret's stories around hepatitis C. There's some pretty major opportunities to build on that floor that CMS has laid out. For instance, states could include prescription medication in the pre-release period. So that 2 to 3 month treatment could happen in the days or months before somebody even leaves the carceral facility. And then states also have the ability to identify broad or narrow eligibility criteria. So some states have sought programs that will apply to anyone who would be eligible for Medicaid, if not for their incarceration status. And other states have gone for more narrow eligibility, like specific conditions such as serious mental illness or substance use disorder. And then in addition to those components, states are also responsible for identifying the length of the window of pre-release services. We've seen a range from 30 to 90 days so far. And then states also must identify whether they will implement these services in youth correctional facilities, state prisons, jails, or a combination of the 3 or just one. Thus far, we've seen some states omit jails from their proposals, and others have gone for more expansive programs. So there's a lot of variety in these waivers. Those are the foundational pieces of the reentry waivers, but I personally don't think that they capture their full potential. So let me talk a little bit about what we've been studying in terms of the opportunities for innovation. So we've seen a big push from the Center for Medicare and Medicaid Services, as well as federal policymakers who were behind this change, to include people with lived experience of incarceration in design and implementation, and to think about the ways in which they might participate as service providers. So as you might recall, I mentioned that case management is a required component of these waivers, and there's an opportunity there to employ folks with criminal legal system involvement experience. And I think doing so has a twofold impact. It assists in addressing employment issues for people who have been incarcerated, which I think, as we just heard, can be a really significant barrier to reentry. And then it also provides an opportunity to meaningfully break down instances of mistrust. So, right, many people who have been involved with the criminal legal system have, an underlying mistrust of service providers or folks associated with the criminal legal system in general. And by positioning people who have been in that situation in care teams, we have an opportunity to build relationships that might engage folks in care a little bit better. The waivers also require states to reinvest money into programs that support health and reduce recidivism. So some states have taken that opportunity to reinvest money to fund more expansive services. So as I mentioned before, some states have gone with just that floor, those 3 required services, but you can build in things like lab and radiology services. You can build in pre-release prescription coverage, and states are able to take money that they save from these waivers and use that to build out those services further. But we can also be even more creative with them, which is where I'm really excited about these waivers. They provide an opportunity to potentially invest in services that reduce reliance on the carceral system, especially for people with health issues that are criminalized, such as mental health issues or substance use issues. So we could potentially build out services that are in the community where we know people are healthier and thrive more, and reduce our reliance on the carceral system, which I think we heard earlier is a pretty significant reliance. And then lastly, these waivers also offer a chance to break down the silos in which different state agencies work. To be successful, a waiver is going to inherently require some level of coordination between Medicaid programs, correctional agencies, managed care entities, healthcare providers, social service providers, and the communities that have been impacted by mass incarceration. And that sort of coordination involves more information sharing, more infrastructure, and hopefully it also gives advocates and health policymakers more insight into carceral health than we've had to date. And that insight could lay the groundwork for future evidence-based interventions, further innovation in reducing reliance on carceral systems for health issues, and building out resources in the community. So I see a lot of opportunity. However, the waivers are going to require folks like those of you in this room really engaging with them and keeping an eye on them and pushing them to be the best that they can possibly be. So if you're wondering how you might find out what's going on in your state, or you want to learn more about reentry waivers, I definitely encourage folks to check out some of the resources we've developed, namely the tracker, which goes over whether or not states have sufficiently included a focus on HIV and hepatitis C. We have a short piece on ways to maximize the waivers potential, which was shared in the chat a little bit earlier. And then we have some really great panel discussions from a symposium we held last spring that featured a number of different people who either work in or have experienced the criminal legal system. And as these waivers move forward, we're really going to need folks from all walks of life to ensure their success. And that can mean anything from writing public comments to your state, to the federal government, working alongside your Medicaid agency, crafting sign-on letters that call out missed opportunities or ongoing issues, or even just finding a coalition of like-minded peers to resource share and coordinate feedback. Those are all things that we've been involved in. And so far, I'm happy to say that we've seen some really big successes by simply just reaching out and calling out these opportunities. We're seeing Medicaid programs really excited and energized by these programs, and I think they want to see them succeed as well. And they're also aware that these are pilot programs, that they're, only approved for 3 to 5 year periods, and they're going to have to go back into a renewal process where they're going to have to show the efficacy and success of these programs. And so there's a real willingness to engage with folks that have that on the ground experience and use that expertise to make sure that we're able to keep these programs running, and maybe in the future see a removal of harmful policies like the Medicaid inmate exclusion policy. So that is my overview of 1115 waivers. And I think with that, I'll pass it back to Kara.
Thank you so much, John. Yes, there is a lot to digest, I know, with 1115 waivers, and I'm eager to learn kind of from our audience what the thoughts might be. So why don't you all start kind of inserting your questions into the chat, or raising your hand on Zoom, either one. And I have one question just to kind of start us all out as a full panel together, while folks kind of insert any questions that they have into the chat or on audio on Zoom. And kind of in reflection with this, I feel like we had a little bit of like where we've come from, what we've tried, and potentially a little bit of like what might the future hold. And in reflection to all that, I just like to kind of ask our panelists what your thoughts are, moving into particularly the next, couple years, regarding where you find yourselves feeling like activated in your respective fields, and what like activation and advocacy might look like for each of the kind of spaces that you're connected to and coming from. So Dr. Bassett, I know you're more on the kind of right now on the health and human rights and
Yes.
academic side of things. What does it look like for you kind of in the next couple of years to think about where your activation and energy is headed?
Well, I think that that we should have a robust conversation about the 1115 waivers. I mean, of course, I expect most of you have heard that Mehmet Oz has been nominated as the incoming head of the Centers for Medicare and Medicaid. So these are waivers for which you apply. I pushed hard as the New York State health commissioner to get a waiver to cover the undocumented, something that had already been done in Oregon and North Carolina, that would have allowed us to provide that insurance. So we weren't able to get the political support that was needed to put that through. So you have to have the political support of your, of your state. And then then it's an application. It's not guaranteed that the Centers for that CMS will approve it. And maybe John can tell us. But this disruption in people's health care, which occurs even when you're jailed, which may only be for 2 weeks, is a real challenge to the continuity of care. More creative ideas would be to have the same service, community clinics, for example, which has been tried in some settings. In Worcester, Massachusetts, for example, they were doing this. Look after people both inside and outside, so that there would be one provider that people would be familiar with, so that when they went back. So that's, I think, really important. I think it's really great to have mobile clinics. The problem that I'm not sure was clearly articulated is continuity of care. People may not have stable anything, and they may not be able to find their way back to the van. And so, there are real difficulties with the management of any chronic disease, including hepatitis C, when people will have a lot of trouble being adherent to the medical regimen because of the fact that they have to find their way to care. So anyway, that's my thinking. Everybody should be working on Medicaid. That's the closest we have, to access to care for many low-income individuals. Apparently, not very effective in the state of Alabama, unfortunately. But in many states, even North Carolina, agreed to expand Medicaid recently. So that's what I would recommend to the group. I will, continue to advocate for universal state-funded health insurance.
Yeah, and John and Sanjay and Margaret, please feel free to chime in.
Yeah, totally echo everything Dr. Bassett said. There's so many limitations to this kind of episodic, mobile, or even community-based care where you can't do the full continuity of what we feel like people deserve. I think kind of on the spectrum of like what is politically realistic to like what we would aspire to, like politically realistic, this model of really supporting federally qualified health centers to be a backbone of like publicly funded primary care. These folks are doing God's work in places like Alabama and the Deep South and across the country. There are models like the Transitions Clinic Network of folks doing really amazing work across the country, embedding clinicians with a particular eye to justice-involved populations in FQHCs, having community health workers kind of fill the gap. I think like advocating for funding of FQHCs, which has historically had bipartisan support in this moment, really pushing for a transitions clinic model to be expanded, supporting 1115 where it's possible. And I'd argue this might be a moment for where expansion, we've been saying this for a decade now, but where expansion may have, again, more support. There's some movement in North Carolina, some movement in Mississippi, there's some rumblings in Alabama when we were there. That feels like, there's an economic and a moral case that's not going away. But then to Dr. Bassett's points, we need Medicare for all. We need single payer health insurance that guarantees healthcare as a right. We can't talk about any of the stuff we were seeing without going back to the EJI narrative of there's a history where we've decided some people's lives are not worth others. And I think the only way that we feel like we can do that is everyone in the same pool, guaranteed health insurance for all.
I think one other thing to add to that, as a, when we work on that long-term vision, for us personally, hepatitis C has become this clear focus of like, when else do we as physicians have a chance to cure a life-threatening disease? But like, really, the medicine is not the tricky part. The pill, that's not the challenging part. And this is also something that's had bipartisan support. Francis Collins, who was the head of the NIH for many years, sort of led the Human Genome Project. This is his new big focus. He's been working to get a bill through Congress that would provide a ton of funding for everyone on Medicare, Medicaid, and who's incarcerated to cover the cost of the hepatitis C medications, which is often a barrier or a complicating factor to getting people treated. And so that, well, not easy, is maybe a more incremental step towards universal healthcare for all, and is something that we're particularly focused on. And there's hope in the next few months that it will get introduced in Congress. So something else to look out for.
I need to correct something. It's not Worcester, it was Springfield, Massachusetts that was using FQHCs. Sorry. Go ahead, John.
Thank you, Dr. Bassett. Yeah, I mean, huge shout out for the hepatitis C national elimination plan. I would love to see that go through. And I think in terms of like inspiration and where I'm drawing from in these moments, it's exactly what's already been talked about. It's folks in FQHCs, it's people who are doing the work right now, regardless of whatever administration is in power. And I feel that my role as a lawyer is to support that work and to stay nimble and flexible and think about how to use the law as a social determinant of health in ways that support those goals. And I continue to reflect on some of the smaller successes that we've had, like, Massachusetts, for example, with our 1115 waiver, is just about to get a community feedback forum up and running, in which we have folks from FQHCs, folks who have been involved in reentry services, all joining together to give input on this 1115 waiver and think about the ways that it can be utilized to build out support in the community and build support for folks who are behind the wall.
Absolutely. Yeah. Thank you so much. And Katie, I might pop it over to you to start us off with any questions you've received from our Q&A. I just wanted to put my email up again and thank you so much for all joining. I'm going to stop sharing so that we can see everyone's faces in case some of our audience members might want to ask on audio as well. So Katie, I'll hand it over to you.
Terrific. So we don't have any questions that have already been asked in the queue, but I do want to echo Kara's entreat to the audience to ask a question. But in the meantime, I have one that I would actually love to hear you all speak about. And I know John and Dr. Bassett, you've both spoken specifically about jail detention as part of this conversation. And I think that is, for me, a concern about what is the actual kind of implementation look like for 1115 for populations that don't have a set release date, right? So many people who are held in pretrial detention are held either indefinitely or on a bail amount that they might at some point be able to have their family raise enough funds or forego other household utilities and then pay suddenly, and then they're released. So I think I feel like there's a gap in this conversation that doesn't address what happens for populations that have sudden release dates. And I wondered if we could speak about that, or if there's anyone who's working on that particular component of the problem.
I can jump in. So I mean, you're hitting like the topic of the hour with 1115 waivers. Some states have taken that approach that I talked about earlier, where they're just focusing on prison facilities. And I think that that's a strategic choice on their end to say that prisons don't have some of these issues that jails do. And so they're going to focus on building out those systems really effectively in those settings. But I am really excited for the states that have chosen to include jails. And they're coming up with some innovative ways to think through this. And some of that is building out that infrastructure that I talked about, right? Like if you're going to have sudden release dates, you need to be able to have really robust communication between the Department of Probation, Departments of Corrections, the Medicaid agency. And that is being built out in what is a required component of the 1115 waivers. It's called the implementation plan. For anybody who is like a super nerd and wants to go through a 700-page document that runs you through all the nitty-gritty details of an 1115 waiver, they are available on Medicaid.gov. You can also check out California's through our tracker. And then there are, places, again, like Massachusetts, who are taking an approach where they have done the math on the average length of stay in jails. And because that is generally below 90 days for the entire population of people incarcerated in Massachusetts jails, they are willing to maintain coverage for folks under the assumption that they will only be there for 90 days or less. And they're going to be reporting every 6 months to CMS whether or not they've been able to maintain a general coverage area for folks. So, I think it's going to go state by state, but at least that example gives me hope that we're thinking critically about what this might look like. And even in some cases, you might have folks who are getting coverage beyond 90 days.
Thank you so much for
Absolutely.
that. Oh, Dr. Bassett, you're muted at the moment.
Unclicked it. Thank you. This came up, if I can just jump in and as the questions are coming in New York City, which, as you know, Rikers is a very big jail. It's not as big as LA's but there were, at the time I was there, I don't know, between 8,000 and 10,000 people at any one time incarcerated in Rikers Island. And the question was, I don't know if this was public or not, but there was a large donation of hepatitis C medication. And at issue was like, will we have these people long enough to treat them to cure? And it turned out that if you didn't get released within 2 weeks, you were probably going to be there for months. And our real doctors can tell us, I think it's about 12 weeks on the treatment course. So, for those people who were still there after 2 weeks, I made the case that we ought to initiate treatment for people found to be hepatitis C positive, because the odds were that they could be treated to cure. But that was dependent on a drug donation. I mean, there really is no reason that we shouldn't be taking absolute advantage of the horrors of incarceration to treat people to cure. Because the main challenge is always adherence. I mean, nobody takes their medicines. I don't, as directed. It's hard for everybody, and that's what the data shows. It's not it's related to the ease with which you can adhere to care, not to your education, your income. It's simply about ease, and whether we like it or not, for people who are, are deprived of their freedom, they can get their medicines delivered by while they're incarcerated, and it really should be a priority to eliminate Hep C in our incarcerated population,
Well, that leads perfectly
starting
into
in the jails, including the jails.
Absolutely.
Yeah,
Absolutely.
yeah.
That leads perfectly into the next question we've got from Hella, who sent it to me as a direct message, but is going to unmute and ask her question. Go ahead, Hella.
Yes, thank you so much for this conversation. I was wondering if the panelists could address the high cost associated with hepatitis C treatment in this country. I know that Egypt has made some great progress in that area, but what, if anything, could we do here to just make it more accessible?
Yeah, that's a great question. That is one of the limitations. When these new meds are so effective, they came out about 10 years ago, and they were the most expensive meds at that time. There have since been even more expensive meds, but they're still running like $30,000 a course out of pocket. I think a couple things. One is that this bill that has been building in Congress would just provide a huge federal investment. It would take it out of states' hands, it would take it out of individual Department of Corrections. It would say, here's enough cash to get for anyone in Medicare, anyone in Medicaid, and anyone incarcerated. And it's using a model that Louisiana actually championed called a Netflix model, where rather than say for every patient that comes in, we'll say, here's your $20,000 for your medications. what the state of Louisiana and the state of Washington did is negotiate a set price. We're going to pay the pharma company Gilead or X number of dollars, and we can get as many courses of hepatitis C medications as we need. And so if that was able to be worked out on a national level, you're getting, you're using that scale to your advantage. So that's, I think, one promising, on the horizon. On a really local level, ironically, what we discovered in Alabama, does not have Medicaid expansion. The vast majority of patients we saw were uninsured. The drug donation programs through there's two big pharmaceutical companies that make the medications, Gilead and AbbVie. The programs they have set up for people to get free meds if you're uninsured actually work very well. We were able to get meds for patients in like 1 or 2 weeks for free from the drug companies. That's not like a great long-term solution, and these drug companies are not, innocent players. They're a big reason why these medications are still costing $30,000 despite they have made billions and billions of dollars of profit. And yet there's actually a pretty effective way to get uninsured patients these meds quickly. So on a local level in the community health in certain projects, in certain settings, that works. Across big departments of corrections, across Rikers, across states that have Medicaid expansion, the federal investment is, I think, the most promising development. I don't know if you add anything else.
Curious if others have thoughts.
I think I briefly touched on this, but 1115 waivers do have the potential to cover hepatitis C medication in the pre-release period and for that 30-day period post-release. The key here is that the 30-day post-release period is required. The prescription coverage in the pre-release period is not required, and so is something that you have to affirmatively advocate to the state for. But again, we had success with this. We reached out to Louisiana and said, you have this brilliant subscription model. You have this beautiful hepatitis elimination plan. And when they put out their 1115 waiver, they didn't have pre-release prescription medication. And we simply wrote them a letter saying, we see a massive missed opportunity here. And when their request went to CMS, it had that pre-release prescription medication coverage.
Thank you so much. And I just wanted to thank some of our audience members for kind of sharing some of their experiences working in different community settings, different social work setting, kind of keeping an eye on things that are happening at the local jails. I really applaud that, we continue to be very vigilant, very mindful of kind of what's happening in our community, particularly over the next few years. So I think just wanted to thank Ronald and to Leela for sharing their experiences. And I think I will hand it back over to Katie for any last questions that might have come in.
No, I think we are 1 at time and 2 out of steam. So just want to thank all of our panelists and you, Kara, for moderating this excellent session. We really appreciate you all sharing your expertise and knitting together these different examples to think about how we move forward and try to reduce the footprint of the carceral system and thinking about health much more holistically. Kara, I don't know if you have anything else you want to add to wrap us up?
No, I just wanted to thank you all so much. Please feel free to reach out anytime. And just a huge thank you to our panelists for your inspiring work at all, levels of the spectrum, what we can learn from the past, present, and moving toward the future. And just really brings me a little more optimism going into, I know, what is very challenging work and holding all those tensions. So thank you all so much for being here with us.
Terrific. And again, we will post this recording on our website in the future, and also all of those links that were shared in the chat will go up on our website with that video recording. So if anyone wants to access those resources again in the future, they will all be in one central location. We are back on December 11th. We hope to see you all back then. Thank you so much.
Thank you.
Thank you so much, Kara, Katie, and all.
Thank you, everyone.
Thanks, everyone.
Thank you.